Welcome back to Health, Fair and Simple. My name is Rylee, and I will be leading today's podcast. Today is March 5th, 2026, and we are recording from Flagstaff, Arizona. I'm really excited to introduce our guest, Grace, an emergency medical technician who works in a fast-paced emergency room in Phoenix, Arizona. In the ER, healthcare providers often meet patients and their families during some of the most vulnerable and emotionally intense moments of their lives. Decisions sometimes have to be made quickly, and family members are often deeply involved in those conversations. Through her work, she has witnessed firsthand how powerful family dynamics and cultural standards can be in shaping medical decisions. Families can provide comfort, advocacy, and essential medical history, but they can also create tension, especially when their wishes don't align with what the patient wants or what providers believe is medically the best option. In this episode, we will talk about the ethical challenges that arise in these situations. How do providers balance respect for patient autonomy with strong family involvement? What happens when cultural expectations emphasize collective decision-making over individual choices? And in emergency situations where time is limited, whose voice ultimately guides care? I'll be asking her about real experiences from her scope of practice and how she navigates these complex moments while still upholding ethical principles like autonomy, beneficence, and justice. I'm really looking forward to hearing her insight and learning how fairness in healthcare plays out when emotions are high and decisions matter most. Make sure to stay until the end of the episode, where I'll rejoin the Health, Fair and Simple group to reflect on what we learned from this conversation and discuss how these real-world experiences connect back to the bigger question of whether access to healthcare is truly fair. Hi guys, I am here with Grace. Grace, how are you doing today?
I'm good. Thanks for having me. How are you?
I'm good. Thank you so much for being here.
Of course, excited. I'm very excited.
Me too. All right. Well, just to get started, can you briefly describe what your role as an emergency medical technician is like, especially just working in the emergency room, and what a typical shift looks like for you?
Yeah, for sure. Honestly, every day is I never know what to expect. And that's always how it is in ER. But I always start my days the same. So I will clock in. I usually work from 7 a.m. to 7 p.m. So I clock in and then immediately I go check our code carts, which they're just basically carts with anything we may need from medications to breathing and airway type things, anything we may need in case of, like, if a patient codes, which is when, like, you go into cardiac arrest or respiratory arrest when your heart stops beating or when you stop breathing. So essentially when a patient dies, basically. So I go around and I check all those carts, make sure they are all stocked with everything that we need, and make sure that the oh my goodness, sorry, defibrillators are working properly and charged, and those are basically the machines that we use to shock the heart into like a survivable rhythm, basically. So sometimes your heart can go into really scary rhythms, and sometimes we have to shock the heart, whether a patient is alive or if they're coding, like I mentioned earlier. We have to shock the heart into a rhythm that will make it survivable, basically. So that's what a defibrillator is.
Mm-hmm.
So I go around and I just make sure they're charged and working well.
Gotcha.
And then I make sure our trauma rooms are stocked and like ready for anything that may come in. And in the trauma rooms, basically, we just, most of the time we put codes in there. Again, as I mentioned earlier, just when a cardiac arrest or respiratory arrest, that's what the trauma rooms are for, or anything that is very, very, very life-threatening, extremely life-threatening, where we're not sure if we're going to have to call a code on a patient. So if a patient comes in and they're fine, but then they code, so when their heart stops beating or they stop breathing.
Mm-hmm.
So yeah, I just make sure our trauma rooms are all stocked, as well as our med rooms with like anything we may need, from band-aids to like IV stuff, and like needles and literally anything you may need in an emergency room. I make sure everything's all stocked up just to get a good start to the day.
Yeah.
And set us off on a good foot, basically. Or yeah, that's the right saying.
Get a good start.
Yes, exactly. And then after that, I kind of honestly just run around and help the nurses out with anything they may need. So whether that's for like doing EKGs, which are basically you just look at the heart from multiple different angles and just look at the heart rhythms, make sure everything's working properly. I do anything from EKGs to like IVs. I can put in IVs and draw blood, that kind of thing. And then even just like little things like monitoring vital signs. So like watching a patient's heart rate and their respiratory rate and their blood pressure and all that fun stuff, all that jazz.
Yeah.
But yeah, so I like to say I run around like a chicken with my head cut off, honestly, because it gets kind of chaotic. But
yeah, that's a lot of things to just remember and like
no, exactly,
do in a shift. I feel like for sure. Are there any like specific do you ever get a lot of a certain type of emergency situation, or is it like varied throughout the day? Honestly, or does it like depend shift to shift?
It really just it's so random. I wish I could say that we get more of one thing than another, but it can vary from like actually life-threatening emergencies, like if I don't know, you were in like a really 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 bad accident or something, or to a simple like you're sneezing a lot, you know, like people have their own definitions of emergencies, and we treat everything. So I mean, yeah, it really just depends. We don't really get more of one thing than another, I guess.
Gotcha.
Does that answer your question?
Yeah. And then does like your tasks and stuff like vary from your shifts? Because I know you work a few different like time slots of shifts. Does it change like what you do on the day to day, like, or is it all kind of the same?
It's mostly the same. When I'm not working, when I don't start at 7, so I'll do 7 to 7 and then 7 a.m. to 7 p.m. Sometimes I do 12 p.m. to 12 a.m. Other times I do 7 p.m. to 7 a.m. When I'm not doing the 7 a.m. to 7 p.m., I don't have to go around and check the code carts because whoever was there in the morning does that. But everything else stays the same, honestly. I still make sure everything's stocked up. I will take patients upstairs. I'll clean rooms if it's super busy and housekeeping is like having a hard time, you know, if it's super busy and we have a very quick patient turnover, I guess, if that makes sense, I'll help them out too. It really just depends on the day. Yeah. But the only thing that differs is if I'm not working in the morning, then I won't like check off the code cards.
Gotcha. But other than that, everything else pretty much stays the same.
Yes.
Gotcha. Yeah. Okay. How often, like when you're having an emergency situation, how often are family members like present for that? Is it often, or is it mostly like the patient just comes in by themselves?
Honestly, it varies. I would say that like in a lot of like true life-threatening emergencies where there's a very high risk of a patient passing or being seriously injured, you know, the fire department usually brings those in. I would say like maybe 75% of the time the fire department brings in those kind of cases, and family usually doesn't come. And sometimes it can be hard, like if a patient's unconscious, we can't contact family, so like that kind of thing. But when they bring themselves into the emergency room, I feel like that's when family mostly comes to, because obviously they're all worried and like that kind of thing. So
yeah. And then when like if a patient were to code, like their heart were to stop, is that like your job to like talk to the families, or is that more of like the doctor's job? Yeah, that's more of the doctor or whoever the provider is that day. The doctor normally does that just because they know everything about the situation and they can explain everything much better to the families, because it's obviously a very scary situation to have to go through that, especially as a family member.
So usually the provider will
That's like more in their scope of practice. Gotcha.
Yeah.
In your scope of practice, are you having like any experience like really talking to the families, or is it more like you're just kind of witnessing the dynamics, I guess?
Sometimes I'll talk to the families, but I have to make sure I let them know that I don't have the experience and education that a lot of other people in the department do.
Mm-hmm.
But I try and, when I can, I try and help explain things that I can't explain.
Mm-hmm.
But most of the time I'll just witness it. If it's something where that I don't fully understand, I won't try to explain it and I'll just have someone else. But
yeah, sure.
Yeah.
Well, in your experience, what role do the families like that you interact with or witness, what role do they normally play in medical decision making in the emergency room, or do they have a role at all?
In my experience, I would say there's a lot of different cases where the family would make medical decisions for a patient. Like we, if there's like a kid, if there's a child, they obviously can't make their own decisions technically. So family is there for that. And they will make decisions for a patient or the legal guardian, whoever it may be.
Right.
Same with unconscious patients too. They obviously can't make medical decisions for themselves. So if family is present, then they would play a bigger role in the decision making. But I feel like in my experience, if family is present, even and the patient is able to make decisions for themselves, I feel like a lot of the times, like most of the time, I would say family is pretty respectful of the patient's wishes. If that makes sense.
Okay.
Does that answer your question?
Yes.
Okay.
Have you ever had a situation where a family member's wishes conflicted with what the patient wanted?
Kind of, in a way. Actually, just a couple of weeks ago, we had a patient who dislocated her shoulder. She was in her, I would say, late 80s, early 90s. And there were genuinely like probably 8 or 9 family members in the room. And the rooms are pretty small, so it got kind of overwhelming, but that's besides the point. But we had to sedate her and then reduce her shoulder, which is basically just popping it back into place. And with the sedation, it's a conscious sedation, so we give them like pain meds, and then it's literally a sedative. It makes them really woozy, and so they don't have to really experience it, because reductions are quite painful.
Yeah.
I'm sure. I mean, I personally haven't experienced, but yeah, so we popped her shoulder back into place, and when the sedation wore off, we offered her some morphine, which is pain medication, heavy duty pain medication. We offered her some morphine for the pain after the sedation wore off, and she wasn't sure because she was a very small woman, and pain medication, she said that she didn't like the way it made her feel, basically. So she wasn't sure, but her family had a lot of opinions about what they thought was best for her. And they're all differing opinions, of course, because there's 8 of them in there.
Yeah.
But yeah, they all had a lot of opinions, and I really just eventually had to let them discuss amongst themselves so that they can figure it out. But yeah, so sometimes it gets kind of difficult with that. And then also, like, kind of off topic, but with like cultural kind of stuff, I guess. We have a lot. I had a patient, this was, oh gosh, maybe 4 or 5 months ago, I can't really remember, who was a Jehovah's Witness. And if you didn't know, Jehovah's Witnesses it goes against their religion to, as far as I'm aware, it goes against their religion to receive blood transfusions, because just their religious beliefs. And so we had a patient who was very, very anemic come in, and she really needed a blood transfusion, but she was a Jehovah's Witness and refused it. And so she left, and then I don't know what happened after she left, but it could have been life-threatening. But it's like stuff with that too, it gets kind of difficult. But yeah, I don't know. So there's a lot of like family and cultural dynamics that can affect a patient's care.
Sure.
I guess.
Yeah. And then when those situations like happen. First with like, we'll start with the family members' wishes. When there's situations where like the family members have a lot of opinions and they feel that they know what's best for the patient, and you know, there's just a lot of differing opinions about the decision that should be made. Like, who do you listen to first, I guess? Or like, how do you handle that type of situation? Like, do you focus it more on like them discussing it for themselves, or is that something that you more get involved in, or like just the medical providers in general get involved in?
Yeah, I would say first, obviously, we listen to the patient and go with the patient's wishes. Um, if they aren't able to make decisions for themselves, or if they want their family to weigh in, then I'll let them discuss amongst themselves, because I mean, it's not really my job or anybody's job to get in the way of their decision making, I guess, if that makes sense. So if anything, I'll just let them discuss amongst themselves, and then if the provider needs to come in and talk to them about like what they might think is best for the patient, then they'll do that. But if they want that opinion, like the from the medical standpoint, but yeah, I would say listen to the patient first, do what the patient wants, and then if that doesn't work, then just let the family discuss.
Gotcha.
I guess.
And then how would that work if it was like if it was a child and parents and the child had a differing opinion than the parents? Has that ever been a situation before? Because I know that parents typically have like medical like control, is that the right word?
I guess, yeah.
When they like before they're 18, like they're the primary like decision maker. Right. But like what happens if the kid were to have a differing opinion?
That is a very tough situation. I personally have not experienced it, but it is a very, very tough situation that I actually hear about a lot. And it just like, it's hard because you kind of have to come to a decision of, is the patient old enough to know what's best for them, which I don't know if that might sound weird, but like, you know, a 6-year-old can't be like, no, I don't want a cast, like I broke my arm, but I don't want, you know, like obviously that kind of thing is a lot easier, but it really gets hard. So I would say I personally have never experienced it, but I think that the provider, the physician, PA, physician assistant, nurse practitioner, whoever the provider may be that day, would probably have to go in and discuss with the whole family too. And it really is hard because it's a decision that the family would need to come to on their own, I guess. And it's a very sticky situation. Yeah. I wish I had a better answer for that, honestly.
Yeah, no worries. And then going back to the cultural influence and how like that can kind of affect a patient's care, is there a way that you have to specifically handle that, or is that again just more up to like you listen to the patient's wishes first?
Yeah, you respect the patient's wishes, especially with like cultural type stuff and religious beliefs. It's obviously completely up to the patient, and we are always very respectful of what they want.
Sure.
Sometimes, if like in the case that a patient was, sometimes I guess you have to, I can't remember the exact word, you have to make a decision for what's best for the patient if they're unable to make decisions for themselves. But I mean, if it's in like a life-threatening situation, I guess.
Gotcha.
But overall, you do have to respect the patient's wishes.
Okay.
So
yeah. So
and like you can talk to them too, and like discuss it with them, and discuss why you think it would be best for them to do a certain thing or to not do a certain thing. But overall, it's just up to the patient. So
okay. Yeah. Is there a certain protocol that you have to follow, like when people are leaving, or like when you respecting the patient's wishes like goes against what the provider, like what is recommended? Like, is there a specific protocol that you have to do for that?
I would say it kind of depends. Like if they're just refusing a treatment, maybe not. I don't know a whole bunch about it, honestly. Maybe not when they're like just like refusing, like if they're refusing a blood draw, something like that. No, but if they're refusing care and they just want to leave, there are like forms that you have to sign. It's called again, it's an AMA form, which stands for Against Medical Advice. It's basically when you're leaving against medical advice, that kind of thing. That's that's all I really know about that kind of thing. I'm not completely educated on that, but
Yeah.
yeah.
All right. Yeah, I know that there is like against medical advice forms, and I just wasn't sure if like if someone denies like something, like what the level is, I guess. But is it only if they're like denying like care like as a whole? Like if they're
Yes.
like I want to leave?
That, as far as I'm aware, yes, but I could be wrong.
Okay.
So. But I think so, yes.
Yeah.
I don't personally deal with that kind of thing, so.
Well, and like you were talking about like how in emergency situations like it can be like kind of in the moment like figuring stuff out. How like when you're having stressful emergency situations, um do the family members' emotions like impact any like communication or anything like that?
Ooh,
I know you were saying that
question.
like yeah, I know you were saying during like in like most of the high stress situations, I guess, when they're like coding and stuff, most of the time they come in like on an ambulance and the family's not there, right?
Yes, a lot of the time.
So have you ever had situations like that?
Yes, actually.
Okay.
It gets really, really tough when family is there and there's a life-threatening emergency happening with the patient, like if they are coding. In that case, we'll bring them to a designated family room, which is just, it's in a quieter place of the ER. It's kind of up near the front, so it's a little bit quieter. It's just a little room with some couches and blankets and like all this kind of stuff to comfort the family. And we'll usually bring them into there while we're treating the patient, just to, while we're treating any life-threatening emergencies, I guess, we'll bring them into there. And then the provider will go in and update them on the patient's care and what's happening and try and answer any questions they have. Yeah, I guess.
Okay.
So, because it gets very hard with the high stress situations, because obviously emotions are in the mix of the family, and it you have to be compassionate towards the family, obviously, but also you need to make sure you're treating the patient as quickly and efficiently as you can.
Mm-hmm.
So it gets kind of hard. But
have there ever been situations where like those conversations or the emotions or anything are like impeding the care of the patient, or like I guess not making the care for them like as efficient or like as efficient or as beneficial as possible? Like
yeah, I feel like where I work, we have a good system of like, so we have a good, our care team is good at balancing all this out, so we'll like have someone talking to the family as we're caring for the patient. But when it comes to like when the provider needs to talk to the family, that can be kind of hard, because the provider is also, like, the physician is also the one making the medical decisions. So it gets kind of difficult trying to balance that out sometimes. But
yeah, do you know if like after like physicians like talk to the family, like do you think that their decision, like their medical decisions like that they had for the patient, would be like changed by the emotions of the family? Like do you think that they could, that could like impact the direction of care? Or
some patients have a DNR, which is it's a advanced directive. It's a do not resuscitate. So if a patient codes, they don't want to be given like chest compressions or have life saving techniques given to them, I guess. And so that's something that we have to follow, obviously. But if a family is there, sometimes the emotions will make them want to not respect the patient's advanced directives.
mm-hmm.
So there have been cases where after the provider talks to the family, they do actually want to, give life-saving techniques to the patient, I guess.
Mm-hmm.
Not techniques. You know what I mean. Words are hard. But then sometimes we'll have to respect the family's wishes, of course. But yeah, like that kind of thing. Does that answer your
Yeah,
question? Okay.
that does. So, in like emergency settings like that, like how do providers ensure that they're respecting like the autonomy? Like if the patient does sign a do not resuscitate order, like they're saying that they don't want those life-saving measures
Correct.
on them. So like what would change that, I guess? Like what would override the patient's autonomy?
That can be really, really tricky. If they do have advanced directives like the do not resuscitate order, or like medical bracelets that have, like if a patient has diabetes, sometimes they'll have like medical bracelets or medical necklaces stating that like anything like that, we have to respect that. If a patient is unable to tell us otherwise, unless the family is there, and it gets really weird and tricky, I guess. I don't really know, but it doesn't happen very often, so I haven't had much personal experience with that kind of thing. But it does get tricky. If there is no advanced directive, and the patient is conscious, obviously we just respect the patient's wishes if they can tell us what they want. Or if they're unconscious, we try and contact a family member or your health proxy, which is somebody who is your designated designated person to make medical decisions for you, I guess. But in the severe cases where you have like no information about the patient at all, you kind of have to use implied consent, which is basically just when you assume that like a reasonable person would want life saving measures taken if necessary. So that kind of thing.
Okay. So basically, like if a patient signs a do not resuscitate order, like that's always respected first.
Yes.
And then after that, it would go to like other legal like people if they have them.
Yes. Yeah.
And then it would go to like the family if there are family. And then it would go to implied consent.
Yes.
Okay.
Yeah.
Okay. Awesome.
As far I think so. If my
from what
information
we know,
is correct, yeah, from what I know.
Okay. I guess we also kind of talked about this a little bit, but just to go in depth a little bit more, when you're having like high emotion emergency situations, is there like a way that you've witnessed providers or you yourself have been able to like stay neutral and stay calm when there's like a lot of family members in the room like disagreeing with the treatment? Or like do you interact, or is it more just like kind of do what you have to do?
I would say, like, from my experience, I feel like obviously, like, as a provider, you would probably like just try and stay calm. Obviously you have to stay calm, and then just talk to the family and like let them discuss. And it's hard sometimes because like medically you know what may be best for the patient, but the family, if the family is obviously very emotional, then they need to kind of discuss amongst themselves, and the provider needs to have an open conversation with the family about their concerns so that they can hopefully all settle on a good plan of action, I guess.
Right.
It is all about staying calm, pretty much.
Yeah.
Which does get hard, but you know, you gotta do what you gotta do.
Yeah. Part of the job.
Yep.
Okay. And then just overall, do you think that our healthcare system does a good job supporting the patients and the families during crisis situations, or is there someone that like takes priority? Or
I would say yes and no, honestly. We have a very quick responding like emergency care team, I guess, who can care for the patient, but sometimes it's hard to have the time, as I was saying, when in the high stress emergency situations, it's hard to have the time to fully explain everything to families and answer all the questions to the extent that they need. And sometimes it's also hard because so many healthcare systems are so understaffed that it gets difficult to designate people to talk to the family, I guess. And yeah, I don't know. There are good strengths and weaknesses on both sides of the healthcare system, but I think that it would be good to hire people who can actually speak to the family in these situations. Does that make sense?
Yeah, like
Okay.
have someone designated to speak to them
Yeah.
because I could see how it would be a lot of stress like put on the healthcare workers themselves
Yeah.
to have to remove themselves from like this really stressful crisis situation and then have to like immediately switch and be a calm, cool, collected like
presence
for the family and
Exactly.
like be kind of a calming, reassuring person for them, I guess.
Yeah.
When you know, in the other room, like you're probably
who knows what's happening.
Who knows what's happening, you know. So yeah, that's definitely hard. So I would agree with that having someone that's designated, I feel like some places might have that where it's like a designated like social worker or something like that, but maybe just having like more of like a medical focused thing, like where it's like someone like explaining all of the medical things to the patient.
Exactly.
That isn't necessarily the provider that's like caring for them at the time.
Yeah. And we have wonderful social workers and like palliative care, which is end of life care.
Right.
And just a great like medical healthcare ethic team too. And they are wonderful with that kind of thing as well. But I think you're right. I think it'd be very helpful to have a designated medical professional who could help explain everything that they need to explain.
Yeah, totally.
So
and then is there anything else that you would like want to change about family situations in emergency care? I know that's a pretty broad question, but
yeah, that's okay. I mean, it's easier said than done, and I kind of was just talking about this, but just having someone who could stay with the family, be there in their time of need, because emergency situations are stressful and very highly emotional situations. And I think that it would be great for the family if they could have somebody who's there to be a rock and to answer any question they may have and that kind of thing. And again, easier said than done because hospitals are very understaffed, in my experience at least. But I think that if we could make that happen, it would be a great way to support families in their times of need.
Yeah. I'm sure that would also like help support the patients because like also like if a patient's going through a lot and then their family is like stressed on top of that, then their family like can't be the like proper support that the patient needs.
Right.
Also.
Exactly.
So yeah, I'm sure that would help definitely a lot of situations.
Literally.
Not just in like emergency care, but like
anywhere.
Honestly. Yeah, for sure. Well, that's all the questions I have for you. I really appreciate you sitting with me and answering all my questions and having a conversation with me about your experiences and everything.
Yeah, it was great talking to you. Thank you for having me.
All right, I am joined again by Emma, Jamie, Lucas, and Eileen for our roundtable discussion. After listening to the podcast, I think one of the biggest themes we should start with is patient autonomy. Grace really emphasized that the patient's wishes always come first, even in stressful emergency situations, but it didn't always sound that simple in practice. What did you guys think about that?
Yeah, I agree. It sounds clear in theory, but in reality, it gets complicated fast. Like the example with the elderly woman who didn't want morphine, but her family had a bunch of different opinions. That situation shows how hard it is to actually prioritize the patient's wants and needs when there's pressure from their family.
Exactly. And I also think that brings up the question of whether autonomy is ever truly independent. Even if the patient's technically making the decision, they're still surrounded by family opinions, emotions, and stress. So it's not always a completely free choice.
And I think it also depends on the patient's condition. Like if they're in pain or they just came out of sedation, like in that example, are they really in the best state to make decisions? That kind of blurs the line between autonomy and what's actually in their best interest.
That's a good point, because then it starts to conflict with beneficence, like doing what's medically best for the patient. The healthcare team might know what would help, but they still have to respect the patient's decision, even if it could lead to worse outcomes.
Yeah, and I think that conflict becomes even more obvious in the example of a patient who refused a blood transfusion for religious reasons. That one really stood out to me. What did you all think about that situation?
Honestly, that was one of the most surprising parts. It feels counterintuitive that a provider would let someone refuse a life-saving treatment. But at the same time, respecting religious beliefs is a huge part of ethical care.
And I agree, but I also think it raises a tough question. Should there ever be a limit to that? Like, if a decision is almost certainly going to lead to a serious harm or death, should providers step in more?
But if they did that, it would kind of go against the whole idea of autonomy. I think the system is set up to avoid forcing treatment on people, even in extreme cases. That's why they use things like AMA form or to make sure the patient understands the risks.
Yeah, and I think it also protects the healthcare providers legally. But ethically, it still feels uncomfortable because they're trained to save lives, and here they're basically watching someone refuse help.
I think that discomfort also shows up in the discussion about DNR orders. Grace mentioned that sometimes families want doctors to ignore a DNR in emotional situations. What do you guys think about that?
That was interesting to me. I didn't realize that even if a family is begging for intervention, the medical team still has to follow the DNR. They can't reverse it. It really shows how strongly patient autonomy is protected in these situations.
Yeah, but also it highlights the emotional side of these decisions. Families might not be thinking about the legal documents in that moment. They're reacting emotionally and just want their loved ones to survive.
It also makes me think about how important it is for patients to have those conversations ahead of time. If families understand the patient's wishes beforehand, there might be less conflict in those situations.
That's a really good point. Planning ahead seems like it could prevent a lot of these ethical dilemmas. Another thing I noticed was the idea of implied consent. That's when a patient is unconscious and there's no directive. What do you all think about that?
I think it makes sense in emergencies because doctors need to act quickly. They can't just wait around for permission if someone's life is at risk.
Yeah, but even then, it's still kind of an assumption. Not everyone would want aggressive life-saving treatment, especially depending on their values or quality of life.
That's true, but I feel like it's the safest default. It's better to try and save someone and figure out things later than to do nothing and risk losing them.
I think it just shows how important advanced directives are. Again, without them, providers are forced to make assumptions that might not reflect what the patient actually wanted.
Definitely. And I think the last big theme we should touch on is communication, especially with families. Grace mentioned that the ER is often understaffed and that there isn't always enough time to fully explain things. How does that connect to bioethics?
Communication is a huge part of ethical care. If families don't understand what's happening, they might make decisions based on fear or confusion instead of the clear information provided.
Yeah, and then to add on to that, I think it also can increase conflict. Like if no one's there to explain what's going on, then the families might disagree more or even question the medical team.
I like her suggestion about having a designated person who talks to the families. That seems like a good thing, and that could help reduce stress and improve understanding.
And it also shows that ethics isn't just about big decisions. It's also about how care is delivered. Being compassionate and clear with families is just as important as the medical treatment itself.
I agree, and I think that's a good way to wrap up this conversation. Overall, the podcast showed that while bioethical principles like autonomy, beneficence, and respect for beliefs are clear in theory, they become much more complicated in real-life emergency situations. There's a constant balance between medical judgment, patient rights, and family involvement. Thank you for listening to this episode of the Health, Fair, and Simple podcast. Tune in for the next episode where Lucas will talk more about language barriers with his guest.